pleasure to introduce Dr. Barry Resnik of the Resnik Skin Institute. He's actually local here in Miami. And we're actually all, Dr. Dave Louie is a associate professor at Wayne State University. He's also residency program director there. And all three of us are on the board of directors at the HS Foundation, which is an amazing nonprofit organization dedicated to promoting awareness, research, education in HS. So if you ever have a chance to pop by the website, there's a lot of resources on it. And then also really happy that we were able to work with Novartis was the sponsor for this non-branded CME satellite session, so I just wanted to thank them as well. We also worked with HS Connect, which is an amazing organization that has so many patient resources. We have a representative here, the co-founder and president here. I'll introduce her after too. So really grateful for everyone for their work in putting this together. And I'd like to introduce now Dr. Barry Resnik to the stage and thank him for coming and sharing his wise tips with us.
Afternoon. Let's see. So I am tasked with, in 15 minutes, telling you all about HS, what to look for, how to look for it, how to treat it with a variety of medicines and not including biologics. So this is what we deal with, the acne tetrad. You've got HS, you have dissecting cellulitis of the scalp, which for me is HS in the scalp. You have acne conglobata, and for those of you who don't know what conglobata means, it means coalescing. And I had to look that up because it's not a word we use all the time. And then of course a polynodal sinus or cyst. When I am doing an intake for a new patient, my first thing to say is, let me tell you what HS is and what HS is not. It is a disease of the skin only. It is from follicular occlusion. And when you get those blockages, they cannot be dislodged. And the stuff that comes behind it has no place to go but through the skin. So you've got that explosion and healing. And then you end up with those scarred plaques, I call them ant farms. And you've got a disease of chronic inflammation. It's not infectious. It is not a disease of infection. It's not contagious. It's not sexually transmitted. It's not the fat or the muscle. It is not gland-based. It's not because the patient is dirty or doesn't wash enough. And here is the sad truth about HS, and this is what we are tasked with. This is our mission, to get the information out. Because when you talk to a patient with HS, they feel alone. They are isolated. They isolate themselves because of the smell, the burn, the itch, the sting. They never know what they're going to leave on their couch or someone else's couch or in someone else's car. I'd say about 30% of my new HS patients have not been officially diagnosed. They have diagnosed themselves, or they have seen stuff on the web and they think maybe this is what I've got. 7 physicians or allied healthcare providers, no proper diagnosis, no proper treatment. They are frustrated, they are in pain 24/7, 365, and they are isolated. So, for me, you've got scattered papules, nodules, recurrent in the same sites, 2 or more areas within the last 6 months. The areas it hits are always the inframammary folds, axilla, groin, buttocks. You can see it around the belly button. You can see it in the scalp with dissecting cellulitis. You can see it on back or chest. And if you are looking at that patient, make sure you look at everything. This is a Hurley stage 1. 2 sites recurrent in the same areas. And when you are seeing a patient like this, the first thing out of the patient's mouth is, I'm much worse all the time. I don't know why I'm not as bad. And I said, don't worry, it's like going to the shop for your car, man. Your car's squeaking, the brakes are horrible, and you get there and everything's working like a dream. I said, this is okay. You don't have to convince me that you are in pain and that you're suffering. Here's a Hurley stage 2. You've got a couple of tunnels on the right side. You've got recurrent cysts and boils on the left side. I'm sorry, Hurley stage 1. Yeah, you can see a single abscess. You can see an inflamed epidermal inclusion cyst, or folliculitis, or acne, but you need to take in the totality of the patient. Anyone who shows up with folliculitis, boils, abscesses, I ask them about the other areas. You have lesions in other sites. I screen every new acne patient, when you are talking to an acne patient, this is where you're focusing. Maybe you'll ask about chest or back, but you won't ask about underarms or groin or anywhere else. So we have 3 questions in our EMR that my medical assistants ask every time they do the intake. We're looking at our catch rate, but this is something that will even alert them to the possibility of HS, and maybe they know someone or someone in their family may have it. And I think that we're probably going to see that in our more severe acne patients. We're going to start picking up more patients with HS. So my philosophy of therapy, I always tell patients that we use antibiotics because they're anti-inflammatory. I tell them that taking a culture and treating you with 2 weeks of the medicine that your culture is, your bacterium is sensitive to, is an absolute waste of time. I do not culture HS. If it's disgustingly green and smells and it's thick like a Frosty from Wendy's, I might if I'm taking it out of an abscess. But you can give any antibiotic as an anti-inflammatory and they're gonna get better. They will have response to that. And quality of life versus step. I am not gonna go with the least thing and work my way up, because these patients have already been beaten about the head and shoulders. They are depressed, they are in pain, they want help. And too many times they've seen dermatologists, they've seen other physicians who say, yeah, I'm gonna give you some doxycycline for a month, come back and see me. It doesn't work that way. And ultimately, who am I to say whether they are severe or not? When I tell them, I say, look, objectively, if I put you against 99 other people for that mythical 100%, I'm gonna say, maybe you're 10%, maybe you're 1%, you're bottom. That's good to know. But I say, if I compare you against you without disease, this is the worst you've ever been, that's how I'm gonna treat you. Pain is a big thing. We talk about pain all the time in the foundation. When we're talking about HS, pain is all the time. And I really got that hammered into me. I put a patient on Humira. They came back in 2 weeks for their follow-up, and they said, you know, I didn't realize how much pain I was in until I started the Humira. It is like a new day. And that really clued me in. So when I'm talking to patients, I'm validating a bunch of things when I'm seeing them as a first patient. I'm validating that they're isolated, that they smell, they burn, they sting, whatever they are suffering from, and I'm talking about the pain. I use NSAIDs, ibuprofen 803 times a day, and most patients are on that already. Florida has a medical marijuana card. I push that hard. I have a friend who I went to college with who is now a medical marijuana specialist, so he gets all my patients. I don't have to convince him that this is a severe chronic pain disease. Actually, I took the course when it first became available, and then I realized what an absolute pain in the ass it was to do this. So I let him do this. Narcotics, I am not afraid to write narcotic. Now I will tell you, in Florida, I can give a 3 or 7 day supply for acute pain. Every time we write a narcotic prescription, we have to go on an eForce website and do a report on someone. It'll give us a dependency factor. And I'll see who's writing for them because it culls the information from everywhere. And initially I thought it was very draconian. I don't know if you know the politics in Florida, but it's difficult. I think this is a really important thing that we're doing. And I think it helps when I'm prescribing narcotic. And I'll do it, but if I find that nothing I'm doing is making the pain go away, I will tell them I can't give you more narcotic. You're gonna need to go see a pain specialist. He's gonna give you longer acting stuff, and there's a whole route that they need to go for that. I use a lot of prednisone and intramuscular Kenalog, triamcinolone, a lot. I will use it as a jump start, 80 milligrams at their first visit. When I put them on whatever medicine that I am using to bridge to the biologic. I use a lot of Neurontin and Lyrica. It's helpful. Some people don't respond, but I have to give them choices. No one has given them choices. No one has given them options. I don't want them to feel hopeless. There's always something to do. When you control the disease, you control everything. The pain, the smell, the burn, the itch. So common sense stuff. We talk about dairy. Talk about nicotine in any form. I used to have the question, do you smoke? No one really smokes anymore, but they patch, they vape, they chew. So nicotine is the issue. We always tell patients, hey, morbidly obese, dairy, and nicotine are three things that exacerbate HS. I was born on a diet. It is really hard to look a patient in the eye and say, all right, I want you to lose 50 pounds and stop smoking, and I'll see you in a month. It's not gonna happen. Let's be realistic. I tell them, getting to your best weight is the way to do this. It brings a lot of health benefits, and I'm not beating them about the head and shoulders. Zinc gluconate is a dietary supplement. We've got different cleansers that we want them to use. I use a lot of clindamycin topical. It doesn't hurt, it can always help. Laser hair reduction as an anti-inflammatory treatment. It works, and when I'm giving them information about what they need, I'm always including that. I tell them about mediator release testing, which looks at how your foods stimulate inflammation in the body, and I've got patients who get significant relief from that. Medical therapy, clindamycin topical. Resorcinol ointment, initially it wasn't available. There wasn't any medical grade powder, but now we get it from a pharmacy in Wisconsin. I think there are other compounding pharmacies, and it works well for a lot of people. Anti-inflammatory antibiotics and everything else. Clindamycin and rifampin, I use it for months. Some people are on it for years. And there's a whole bunch of arguments about how rifampin eliminates in 9 days. And it doesn't really matter because I'm looking at the patient and the patient is doing well. Doxycycline, minocycline, sarecycline, augmentin, dapsone, you name it, I'll use it. We have a triple antibiotic cocktail. Rifampin, moxie, and metronidazole for 6 weeks. Then we drop the metronidazole and continue the rifampin and moxie for 6 weeks. And the third week is Bactrim once a day. And that helps a lot of people. The more choices you have, the more likely you are to help them. Spironolactone and OCPs like Yaz or Gianvi, metformin, dutasteride, isotretinoin and acitretin, I don't see them helping much for disease below the chest. Dissecting cellulitis, isotretinoin is the treatment of choice, in my opinion. I use a lot of cyclosporin as an adjunct to biologics when I haven't quite gotten them where we want to be. I use methotrexate. I start methotrexate when I start Remicade to reduce autoantibody. Ertapenem is an amazing medicine. It is a bridge over troubled waters. It's a carbapenem antibiotic. It's anti-inflammatory. It is antibacterial, but remember, it's the inflammation we're working on. And you culture 100 different HS patients, you're going to get 100 different bacteria. Ertapenem works across the board, PICC line or IM, and I just learned that a tunneled PICC line is much better for prolonged treatment. And I'll use it up 3 to 4 months, even longer than the 3 months I have there. Procedural options, IND with punch, intralesional cortisones. I use clindamycin in my intralesional cocktail. I do HS on roofing. I do superficial radiotherapy primarily for buttock involvement, really extensive buttock involvement. Some people use Botox, the Nd:YAG laser, just as a treatment for areas. I've never really seen it work. Cryoinsufflation, I may be the only guy, maybe Steve does it as well in the United States, but I do it when patients ask. I don't think that it works really well. Here's your superficial radiotherapy. You've got a guy with really extensive involvement, and what I'm looking for is all those little tunnels in there, because you know that's the biggest ant farm that I could get my little kid when I was a kid. You're killing all that stuff within the tunnels and you get no leakage, and he has a lot less pain. Here's the burden of HS. You've got these ant farms, large, mounded, scarred, plaques, underarms, groin, onto the scrotum, vaginal lips. They hurt, they ooze. When you remove that with a particular surgery, you're removing the source of the pain. Like, just reach in, take that out, then they're going to have a little post-op pain, and that's it. It gives the patient, if I get rid of it all, the possibility of life without medicine. And you need to remember something. Patients don't want to be on medicine all the time. They're very reticent to take it. Doctors believe in better living through pharmaceuticals. So when I am telling patients, you have a disease with a medicines deficiency, when we fill that deficiency, you're going to be on that medicine forever, but you shouldn't look at it as a life sentence. You should look at it as a new life, because you're going to feel human. Everybody wants to feel human. So here you've got that scarred plaque. More scarred plaque. You see it extends up onto the breast. It's leaking, it oozes. Patient's holding her arm up because I am asking her to. Otherwise, they're in the HS sit. They're not moving. Here you've got very extensive involvement in the groin. Stage CO2 marsupialization. This is what I do for a lot of my patients. You see, I've got a right axilla. I dissect it off of the fat. I don't take anything more than I need. I will take a probe and go around the area to make sure I don't miss any of those tunnels. You can see healed probably 3 to 4 months. The same thing. This guy came to me from a colorectal surgeon. He had disease on his backside as well. What they wanted to do was essentially cleanse his groin and buttocks, put a diverting colostomy in, and then muscle and skin grafts and split thickness skin grafts. Could I do anything? Because they heard about the surgery that I do. And you can see that I could. Here's another one. This is the same guy. Those little rubber bands are called setons. I have no idea what they were. They thought this was a polynidal sinus. Got an ultrasound, there was no extension. I took it away, and he's got a much better looking tush. So, resources. HS Place, you can contact me and I will get you on it. If you have a desire to help, and if you've got patients for whom you need help, because we all need help to help these patients. Super groups, HS Connect, Hope for HS, there are a whole bunch of Facebook groups. The more we accept the fact that patients need information, the better it will be for everybody. So, I'm always learning and always teaching. You can always call me, and I'm happy to get you on that listserv whenever you wish, and I appreciate your time.